men, or women, without the pre-existence of diabetes and hypercholesteremia, but that's a daily intake of eggs. Since the dietary cholesterol intake is relatively low in the United States, it is now regarded as a weaker predictor of disease than the saturated fat. Only minor emphasis on this factor is currently needed because cholesterol was taken away from most of the fat. So it's really, in the big picture, cholesterol does not contribute to the coronary artery disease problem. So with this, I only wanted to show you a very important thing. If you want to switch anything for anything, the two most problematic things, if we ever do, is to switch carb for mono, or you switch carbohydrate for polysaturated. Actually, always the fat wins over carbohydrate, especially the good fat. So if you want to switch, you should not switch your good fat for carb. You actually do the opposite. You drop your carbs and increase your good fat. Everything else, this is all raises the risk. Everything else you do decreases the risk of coronary artery disease, including if you switch your carbohydrate for saturated fat, you shouldn't do that. But if you do it for the unsaturated fat and the mono, actually it decreases your risk of coronary artery disease. Now, what about carbohydrate? We talked about that. There's also a lot of studies on carbohydrate, which everybody confused about. It had been assumed that complex carbohydrate, everybody is told that, oh, brown bread, brown rice, brown this, that complex carbohydrate causes a smaller rise in blood glucose than simple carbohydrate. This is also debated, which I'm going to talk about and why. Growing body of data, however, contradict this. And an example, postprandial glycemic response to a potato and white bread are similar to the response to pure glucose, indicating that complex carbohydrate may not differ from simple sugars in the effect on plasma glucose. So what are we going to do? Which carbohydrate are we going to pick? So despite wide decrease in the consumption of fat and concurrent increase in carb intake, the prevalence of diabetes and obesity in the United States has risen in spite of all these interventions. And serious concern has also been raised over the dietary recommendation of high carbohydrate, low fats. These diets raises blood glucose level, insulin, triglyceride concentration, and reduces the good cholesterol, which is high density lipoprotein, and creating a now well-recognized metabolic profile. It's the insulin resistance syndrome. So what are the new concepts? So how are we going to pick our carbohydrate? We talked about fat, now we need to know how to pick our carbohydrates. We use two things, the glycemic index and recently the glycemic load. This is a new concept. The glycemic index, it's a measure of the relative impact of carbohydrate containing foods on blood glucose. It evaluates the incremental rise of blood glucose after an ingestion of a food that contains 50 grams of carb compared with the same amount of carbohydrate from a reference food, usually white bread or pure glucose. Controversy around this concept is also huge, especially regarding the clinical usefulness of the glycemic index, but mainly due to the lack of long-term data. Not like it's not valid, it's this we need more to learn from. But the glycemic load seems to be more appropriate thing to look at when we look for carbohydrate. It's because of the argument against the glycemic index concept, because the claim is it cannot capture the entire glucose raising potential of a dietary carbohydrate, because the blood glucose response is influenced by not only the quality but also the quantity of carb we consume as well as the quality. Therefore, a new concept risen, and that is the glycemic load, which is the product of both the glycemic index as well as the quantity. So give you the overall picture, or let's say the area under the curve, how much we eat, what's the rise, and and what's the fall of the glucose in the blood. So therefore came the glycemic load, which is defined as the product of the glycemic index value of a food, which is, you can find it if you go over the internet. There are charts and tables of both glycemic index and loads. And it gives you the multiplication product of the load. If you consume this amount of gram of bananas and this amount of bread, and you'll see that there's probably the brown bread is better than bananas, but it's all calculated for you. It gives you index and load. So it's defined, as I said, the product of glycemic index value of food and its carbohydrate content, and it looks like the load incorporate both the quality and quantity consumed. And how do we use this in clinical practice and for the general public? We use it, we have certain values. So when you look at those tables, you will find out certain values we go by. They're generally applied for defining the index of the particular food. So low index, which has 55 or less, medium 56 to 69, and the high glycemic index, anything 70 and above. Well, the value regarding applied the load, low glycemic load is 10 or less, the medium glycemic load 11 to 19, and high is 20 and more. So there are several means to achieve a lower load. We replace carbohydrate with protein, we replace carbs with good fat, I must say, and substitute a low glycemic index carb for a high glycemic index carb. And when we combine the whole three methods, we come up with a good diet. And precisely which strategy would work best for healthy weight control and reduction in diabetes and cardiovascular remains still uncertain. Nevertheless, available evidence is in the support of an overall low glycemic load diet. Is that good? So now we'll talk about weight loss. So this is all about diet and how are we going to improve our sugar, but what about if we wanted to lose weight? What are the principles and things? The weight loss is directly related to the difference between subject energy intake and the energy requirement, as we all know. And we need really, in all honesty, 500 kilocalorie per day deficit result. Then and only then you will have some weight loss, meaningful weight loss, which is usually the healthy weight loss is 1 pound per week. However, there's a wide variability between energy requirements and influenced by fidgeting, gender, age. They studied all of these. It does have a difference on the overall weight loss. And men loses more weight than women. Did you see they gain less and loses more? It's so unfair. But because of similar height and weight, and older subjects of either sex have a lower energy expenditure and therefore lose weight more slowly than younger people. And the variability, why people, we always see that some people say, oh, I did the same as my husband, he lost 15 pounds, I lost 5, or even my friend. It's because many trials attributed this to hormonal changes. People have different hormonal profiles, so the weight loss really cannot be identical. Neither we should expect it to be identical. There are so many contributing factors to the final weight loss, even if we all of us in this room did exactly the same length over a period of time. So reducing the glycemic load is one of the things, as I mentioned, may be especially important to achieve weight loss among individuals with high insulin secretors, like the type 2 diabetes, the obese type 2. And a low glycemic load diet has beneficial effect, has been shown beneficial effect on the high density lipoprotein, which is the good protein, the good cholesterol, and on the triglyceride, which is one of the primary risk factors for heart disease, and but has no effect on the low density lipoprotein, which is also one of the major problems, which we can achieve by decreasing the saturated fat and eating the good fat, the monosaturated, the canola oil, the olive oil, and staying away from butter and even the margarine. That's the thing. So what's the goal of weight loss? The first goal is to, for any overweight individual, is to prevent. Believe me, maintaining weight is as hard, if not harder, than weight loss. It's very, very hard to maintain weight. There was a study mentioned that 5 calories a day over 1 year period cause people to gain 10 to 15 pounds if they don't do it. Nothing is done and no change. And that is like a chewing gum. So basically maintaining weight is really hard work. And losing weight is harder. So, and we always have to identify realistic goals. Nobody should say, I have to lose 100 pounds in 5 months or something. It's hard. We have to set realistic goals And a successful program of losing weight will lead to, a successful program is when you achieve a 5% weight loss, and a loss of more than 15% regarded as an excellent result, and a body mass index between 20 and 25 put the subject at the lowest risk category of all causes of morbidities and mortalities. So this is for physicians and maybe the medical students, and we really have to identify certain things when we evaluate, and even when we look at ourselves, we identify how much we are overweight. What is the problem? Where is the fat distribution problem? Are we apple-shaped? Are we pear-shaped? Because apple-shaped is associated with increased risk factors, the waist circumference issues, intra-abdominal fat problems. And if there is any treatable cause, we look for things to try to treat. And as I mentioned in the beginning, that very few things are like causing obesity and it's treatable. So therefore, we look for these if there is any hope, like, hormonal imbalance, thyroid issues, we treat those and help the patient. But at the same time, this is by no means is replacing the change in diet and cutting down calories. With the patient risk, and we also have to evaluate risks of morbidities and mortalities, and then a comprehensive approach. Usually it's a team approach, really, that we help the patients with. Basically, the principles are, to make it simple, we have to decrease our total energy intake. I have a lot of patients come to me, I exercise Dr. Al-Zubaidi 5 times a week, I do 1 hour, whatever. And I said, what did you do about diet? I eat healthy. And all of what you talk about is high glycemic index, high fat this, but I'm exercising. Everybody thinks exercise causes weight loss. Exercise do not cause weight loss. Exercise helps you to maintain your weight, improve your metabolic problems, but do not cause weight. The principle is to decrease the total energy intake. You maintain a balanced deficient, as I said, at least 500 calories per day, and you increase the physical activity, which will promote you and help you by increasing your basal metabolic rate, but it will not be the only and one and only thing you do, and hope to lose weight. And of course, you always adjust. By the last sentence, I mean, we all know what's plateau, and we all know if we lose weight and we get stuck after 10 pounds and we can't move on, this is when this adjustment of energy intake has to take place. This means what you are taking right now is equal to your energy you are breaking or using, and therefore it's time to change. And change meaning cut down further on the energy intake and or combined with more physical activity. Without this, you will not be able to bypass this plateau. Change is warranted when we reach plateau, and we have to adjust. We cannot do the same over and over, and we're thinking that this will continue until we achieve our goals. It doesn't work. Because your body fights you. The brain is so finely tuned that it antagonizes you along the way of losing weight. It perceives starvation and therefore shuts all your metabolic processes, and therefore it fights you. Everything calms down, and then you need to do way much more to be able to achieve better control. Of course, as you all know, that nutrition is part of the weight, and we do use medication for certain. Exercise helps, as I said, not weight loss, but helps you to maintain. And behavioral treatment, it's all talking about diet, eating at night or snacking or high, there's so many problems in our pattern or behavior patterns in terms of dietary consumption. And of course, pharmacology and surgery is one of the very legitimate ways of dealing with weight gain and obesity in the right circumstances and the right patient. Physical activity, just one slide on physical activity. It does improve, as I mentioned, glycemic control, insulin sensitivity, improve body composition, and to improve hemostasis factors like thrombosis and cholesterol, improve blood pressure, decrease overall risks, protect against weight gain, and we have to really put it as a prescription. Physicians do write prescription for exercise, and as you see, I did not say cause weight loss. This is the algorithm of managing obesity. It includes all the things I mentioned, including pharmacology and surgical management, which is always, we incorporate everything, including those. And the pharmacology we use, we have to achieve good results too, at least 5% below baseline by 6 to 12 months. And drug therapy is not a cure. We always tell the patient, but it's part of a comprehensive approach. Actually, when people take medication to reduce weight, we always mention that just watch what you eat and see how much the amount, and they say, oh yeah, I decreased my amount of food and I lost weight. So even people think they're eating healthy and they don't eat much. When we give them these medications, they really decrease the amount of food consumption and they do lose the weight. And actually it's like a teaching method to them to show them what can they eat in order to lose weight. Anything beyond what they did